patient walking into your clinic come to see you, how do you examine them and how do you sort of pick up the melanoma at the earliest stage without doing a whole bunch of unnecessary biopsy and sort of turning your patient into a Swiss cheese? Because that's another fear
Well,
the patient have, right?
absolutely. And if I can make one more comment, Dr.
Sure.
William, about risk mitigation, you know, you drive probably the most dangerous thing you do is not go out in the sun. Probably the first most dangerous thing you do is get behind the wheel of a car. And how do you mitigate the risk from that? Well, you follow the rules of the road. You don't drink and drive. You drive defensively, but you aren't going to stop driving. And the same as with out of doors activities. This is Arizona. People are going to be outside recreating. So you do risk mitigation, just like you do when you drive. Put on a hat, put on the sunscreen, and use the recommendations that we perhaps are going to get into in a little bit. But risk mitigation is, I think, very important. And I think it's important to stress that in a melanoma patient.
Yeah, I
Now, what
completely
do I
agree with
do?
you. I mean, I completely agree with you. I mean, I think you and I share the same sentiment, right? Just because you had a melanoma, it does not mean you should stop living. And there's a lot of benefit by doing outdoor stuff. But coming back to the question that is, what do you do when the patient walking in your clinic and how do you examine them and what's your process so that, you can detect the melanoma at the earliest stage without performing a whole bunch of unnecessary biopsies?
Well, we do full body examination, and we start going through the hair, and I end up looking between the toes and everything in between. I don't typically do genital examination in women, but I always bring up to them that if they would like me to take a look and see if there's anything untoward, I'd be happy to. But I always tell them that if they choose not to, that when they get home, they should take a hand mirror and examine themselves. And if they see anything that is of concern, let me know and have me take a look, or I can make arrangements if they're more comfortable with one of my female colleagues to take a look. Have them take a look instead. I look for lesions that are outliers, and I suspect that in other materials that you're generating, Dr. Wang, you're going to get into those kinds of things, what patients should be looking for specifically. But I review that with them. I
You
talk
mean
about
specifically the ABCDEs of melanomas?
I do, but I also tell them that our colleague, our friend Ash Margoob has come up with the ugly duckling,
Yep.
and ugly duckling is actually probably better than ABCDEs for detecting melanoma. But why not do both? So you look for
You want to
the
just take a moment and just sort of explain to folks what ABCDE and what ugly duckling is?
So ABCDE was invented by a fellow who's still living, one of the finest dermatologists alive, Al Kopf, grand old man. He's in his 90s and still probably knows more than I ever will. And what they are ABCDE. A is asymmetry, B is an irregular border, C is variegation of color. That means irregular colors with multiple colors. Typically, that's what variegation of color is. D is diameter. And we talk about greater than 6 millimeters in diameter, roughly the size of a pencil eraser. And E is evolution. And evolution means change, but you can spin it. If it's symptomatic, that would fit into the E. So symptomatic mole, one that's itching. That itching is probably new. So in a sense, that's a mole in evolution. And the ugly duckling is what Dr. Margoob did is he noted that, it's usually pretty easy to pick out the melanoma in a sea of other things that people have. It's usually pretty easy to see it because it looks different. Looks
Yep.
different than the other things. Wouldn't you agree, Dr. Wayne?
Yeah, I totally agree. And I think coming back to me, I think the E in ABCDE is more important, especially for the general public. And also I think I mean, you and I probably don't use the clinical ABCDE as much because we rely on dermoscopy, right? And I think I agree with you that ugly duckling, just because, if you have all those lesions, that's kind of light brownish, but you have one lesion that's pink, that's the ugly duckling one, right? And because everyone tends to think that the melanoma is always black, but you can have a pink amelanotic and no colored melanomas, basically. So I totally agree with you on that. And then I think we sort of extend that ABCD, excuse me, we sort of extend that ugly duckling into dermoscopy findings, right? Maybe this is a good segue. So let's say you look them over and from head to toe, obviously, and then what do? Do you use dermoscopy, and what other devices you use?
Well, we take care of a lot of high-risk melanoma patients, high-risk mole patients, as do you, Dr. Wayne. And I have patients that I know I'm going to probably find a melanoma on them in the next year, highly probable. And I'll see it every visit. And those patients, by the way, I don't have come in every 6 months. Those patients come in every 3 months. And we do full body photography in those people. It's not necessary for everybody to have that. But we photograph every mole on their body in groups with about 25 images. And then I take a look at every one of the moles that they have and compare it to the images. Now, I only do that with my high-risk patients.
Yep.
If I see something that
do you want to step back and define what is high-risk patient, right? Because a lot of patients come, they have one melanoma and they have like 10, 20 moles, and they are fearful, right? But what is your definition of high-risk melanoma?
Well, it's one of those, you know it when you see it, but they're moles of different sizes, shapes, and colors. And they're also, and many of them. Lots of moles by themselves put you at an increased risk. And there's one rule that's kind of cute called the 7-Eleven rule, which is easy to remember because you can, go to the 7-Eleven and buy a Slurpee or whatever. But the 7-Eleven rule is if you have if on your upper extremity, you have 11 moles, or on your forearm, you have 7, that puts you in a higher risk category. And, it's reasonable to get checked out. But there are patients, and fortunately, these are unusual cases. They're common in my practice because they get referred to me. Yeah. And to you, Dr. Wayne. But there are cases where it is extremely difficult, even with a dermoscope, to know what the ugly duckling is. They're all ugly ducklings. Yeah. You can't take off 1,000 moles.
No, you cannot.
So we rely heavily on full body photography. And I don't know if the people watching this know what a dermoscope is, but this is a dermoscope. And I have it with me all the time.
Yeah, me too. Like, I feel like, it's not in focus. I feel like whenever my battery runs out, I was like, I can't practice. You have to, yeah.
Well, get another one. I've got about 3 of them. And actually, there's a new one out. Now we're talking shop, but there's a new one coming out that's an
upgrade. Well, let's table that. Talk to us about, like, what is this device and how we use it, basically.
What is the what? Pardon me?
What is dermoscope and how do we use it?
Well, it looks like it's a cheesy magnifying glass that you could get out of a Cracker Jack box, but the fact is, it's about a $1,400 instrument. And what makes it remarkable is it allows us to look inside the mole. And normally you can't look inside the mole because of the light reflecting off the surface of the skin. You're blind to what's beyond it. And there are very clever optics that are built into this that allow us to look inside the mole. It's almost like doing a biopsy in life. And what we look for are the simplest way to put it is we look for order versus chaos. And there are a number of clues that you can that we specifically look for that are warning signs that we apply. But it's basically, is it chaotic or is it well put together? Nature tries to do a good job of putting things together. And but with melanoma, the lesion is defying the intent of nature because of all the mutations that are within the melanoma. So that's basically.
No, I think this is a really, really good point, right? And I think what I'm going to do is on our website, we're probably going to put some pictures of just regular clinical photos of lesions and dermoscopy photos so people can tell the difference, number one, right? And also, I think it's good to mention that, in addition to worrying about melanoma, the same group of high-risk patient will also have increased risk for developing basal cell skin cancer and squamous cell cancer. And devices looking at it with like dermoscope, and you can pick up those lesions as well, right? So do you look at almost every single lesions with dermoscope, or do you skip around? What do you do?
No, I look for, well, it depends. If they've had if it depends on the moles that I see. So usually you can look at maybe a 2 to 3 millimeter, very small, evenly colored lesion that looks like just all the other ones. I don't look at those. I will look at most of them with my dermoscope over 3 millimeters in diameter, and those I'll look at. My high risk melanoma patients that I'm following with photography and then having them come in and comparing photos, I don't look at all those. I look for the outlier, the new lesion, the lesion that's changed, or the new lesion. So you can see a new lesion or a lesion that's changed from the prior examination. I look at those with my dermoscope, and it better be normal. So just because it's new, it doesn't mean it's bad. But if it isn't a textbook example, a teaching example of what a normal mole ought to look like, it's coming off, goes in a jar.
But that also depends on the age of the patient, right? Because if you're a younger patient, they can grow new moles and their mole constantly changing. But the elder patient, you're right, that if you see something new and that's atypical, a lot more suspicious, basically.
Absolutely agree with you. However, with a young person, when they get that new mole, it should look like a mole.
Yeah.
And so it should have the absence of chaos. It should look orderly, this new mole. But even with a young person, if you look at it and it's scary with a dermoscope, it warrants a biopsy.
No, I think here's I think I want to give you. I think one thing is this device that you actually have to know how to interpret what you look at, right? Because plenty of studies have shown that if you just picked up the scope and looking at it without any training, your diagnostic accuracy actually drop. And with training, that will eventually get better in the hands of experts. You can improve it by maybe 20-25%, right? And that's why every year for the last 10 to 15 years, and you run this course at Mayo Clinic, and almost thousands and thousands of physicians and coming and learning that skill set. It's very important. Now, in addition to, so let's step back a little bit. And in your mind, obviously, we sort of established for everyone that, the doctors should be maybe looking at them with the dermoscope, right? And what other tools do you use? Are there anything else more like optical, genetic, anything else that you use?
We haven't been, so there are other technologies that we haven't used because I haven't realized I haven't developed comfort with them yet. Yeah. For example, tape stripping. There's a technology where if you have an abnormal mole, you can take a piece of tape. It's a brilliant idea. And you take tape and you strip cells off, and then take that tape and adhere it to a piece of cardboard, gets sent in, and genetic analysis is done on that. And the problem I have with that, or the reason I don't use it, I don't want to put down the technology. It's brilliant. It's great technology, but it's pricey, and the bottom line is if it comes back as showing that it's suspicious, it ends up getting biopsied anyway, because nobody's going to make treatment decisions, let's say, based on the device. It has an element of false positives and false negatives. The situation where I would use it is if I had a lesion that I was really on the fence on, but leaning toward it being benign, but I wasn't sure, but it was in a cosmetically sensitive area. Then I might use it, because there the ability to exclude a melanoma has value, And the device actually is quite sensitive, meaning that it is pretty good at excluding. It's not as good as ruling it in, but it's pretty good at excluding. So if it says it's benign, it's almost certainly going to be benign. And that saves the patient a biopsy. But even then, it does have some false negatives associated with it. So you wouldn't want to trust it with something that you thought was going to be a melanoma. If you thought it was melanoma and the test came back negative, still you got a biopsy. It's still, probably going to be a melanoma if you thought highly it was going to be. The flip side.
I think you touched two really important points, right? One is I think we have all these great technologies, and I think in your hands, because you're so good in detecting melanoma, just using dermoscopy, other tools, total body photography, the added value is perhaps a lot less. That's number one. Another point I think you brought up is, to me, I think one type of lesion, the lenticle malignant on the face and sun-damaged skin, is very, very difficult, right? And I think, to me, the facial lesion and the nail lesion and the lesions on the bottom of the foot, sometimes those are the three problematic area. It's very challenging to pick up melanoma.
Yeah, I agree with you. The foot we don't have as much problem with, but the problem is if you biopsy it, it's hard for the patient to walk around on it.
Sure.
Facial lesions can be a little bit of a struggle. There's some workarounds that we do, like multiple small biopsies on a larger facial lesion. The problem is that you can't reliably biopsy part of that and exclude a melanoma. Nails can be tough too, because when you biopsy a nail, you're probably going to permanently deform the nail. That stated, most of the time you're biopsying the nail, the patient doesn't like what's going on. They would just as soon have you remove the whole nail, rather than have a large black misshapen streak running down it. So but you're right, there are special areas where that creates special challenges.
No, I think I completely agree with you. And I think one of the most satisfying lesions sometimes the patient come in is if they have some sort of subungual hematoma, like a blood spot under the nail. And this one, like, everyone is terrified, they think it's a melanoma, they're looking online, but you and I can look at it within like 2 seconds. We know this is a very satisfying diagnosis. We can tell someone this is completely benign, no biopsy is needed, right? But I completely agree with you. If someone have like a streak that going from the bottom of the nail all the way to the top of the nail, if expanding a little bit bigger, biopsy in this areas can be challenging, especially when you try to numb the site, right? And then there's special technique you can do that can minimize the deformity, but still, this is a big issue. The nail is not going to grow out perfectly. What about confocal laser microscopy? Do you use that as an added tool for diagnosis, or?
We are trying to develop that. I was actually, Stephen, I was going to hoping to chat with you offline sometime about your experience with that, because we have a confocal microscope and it's a wonderful tool. The problem that we have is that with it has to do with the logistics of setting it up, having it set up and taking the images and so on. But we do use it in sensitive areas. I have to say, we more commonly find ourselves using it to exclude basal cell carcinoma on the face in situations where we're not sure it's a basal cell carcinoma. We think the probability is low, but we can't exclude it, say on the nose, but we don't necessarily want to give a younger person a scar on the nose biopsying. And so we use confocal there quite a bit. That's probably the most common indication for confocal that we have. But I think that the day for confocal is coming. And as the price gets down, as the image qualities improve. The other thing about confocal is you and I have some experience with confocal, but dermoscopy is a cakewalk compared to confocal in terms of the learning curve. So
Yep.
there aren't a lot of people who really feel comfortable doing confocal image interpretation.
No, I think you're right. To me, I think when I was at Sloan Kettering, we did a lot of work on confocal, and I found it very helpful for, again, I use it quite a bit sometimes for the facial lesions, just because it's very difficult to pick out lenticle maligna versus like even pigmented actinic keratosis or solo lenticle, which is an old maturity spot, right? And here, confocal is helpful because you can see the dendritic cells, melanocells sort of coming up. But sometimes those cells can mimic that of the immune cells, right? So that's the difference. And I totally agree with you on the looking at the basal cells on the face. You can look at the difference between like a real basal cell versus intradermal nevus or nevus, like some sort of small papules that help you differentiate that.
Yeah, I think that's going to improve with time, as you know, being quite authoritative on the advances of technology that are occurring in this area. That there is probably within our easily usable clinical lifetimes going to be technology that differentiates those cells that you described, the Langerhans cells that kind of look like melanocytes, are going to be a different color. They're going to be two colors with confocal. One color that'll show melanocytes, and another color that'll show Langerhans cells. And when we have that available, it's going to really up the game, I think, for confocal microscopy.
So